Mike said even I can do it. It works. Okay, that's the definition, which I'm sure most people have seen before or look similar to. This is something that was worked out by the simulation group from the Joint Committee of Surgical Training in the UK. Chris asked me to look at where simulation was in 2011, and we did a survey across the various schools of surgery in the UK to see to look at the state of play of simulation. And following which, presented at JCST, and Chris Munch was chair of JCST time, decided he would create a simulation working group, which was 4 people initially, and then it's got that many on it now. So we've got a simulation working group which has a chair, the JCST chair and the head of JCST secretariat sit on it. There's a trainee support group. The lead dean for surgery sits on that group. And there's representation from each specialty training committee, including core surgical training, and then represented from the College of Surgeons and the ISCP director. And lay members are included through the JCST, and then deanery representative, which is myself in a fashion. This all started with the Technology Enhanced Learning Framework, which is created by Department of Health and published in 2011. And we created this wheel, which basically has at the center improved patient outcomes, safety, and experience. And those items that you can see listed there. The aim was to try and deliver training safely in a safe environment and make it effective and value for money and accessible and equally usable by all trainees and trainers, both during training and for development afterwards. So the working group looked at some of the recommendations from the training framework, and the 3 that we picked on were that health professionals should learn skills in a simulated environment before they practice on patients, because I think seriously should be concerned that our patients would be concerned if they realized we had never operated on anything else before they were the first guinea pig on the table. The group said each specialty should recognize a lead, or identify a lead who would lead on the use of simulation within surgery, and finally look at the curricula and look at mapping simulation to learning outcomes in the curriculum. The group then requested all the surgical specialty leads to review their curriculum, which was coming up to resubmission to GMC in 2 years from then, and to include simulation within that. The process involved basically to say that learning opportunity should offer insight in the development of technical skills, human factors, leadership, decision-making, judgment, professionalism. The groups were asked to look at these carefully whilst they were looking at the curriculum and to try and map it to the various outcomes. That's a slightly busy slide, but that was one of the surveys we carried out across the schools and the specialties to see whether they had a strategy for simulation learning, whether they had leads, what facilities were available, access for the trainees to these facilities. Was simulation being used in any training program within the UK, and was it being shared with other healthcare professionals? The first survey carried out at the end of 2011 and early 12 showed that there was a very patchy use, and most people didn't seem to understand what was going on. There were some units where they were doing a lot more than others, like the York Humber Deanery. They had a huge simulation setup already. So leading on from that, it was felt that the best way to achieve simulation-based learning would be to include it within the curriculum and not as an extra activity. It should be part of it and practiced as part of the curriculum. It should be goal-orientated, and it should be incorporated into the model that already existed in the curriculum for learning. So we could use simulation for simulation-based assessments eventually if we needed to. So it should be regarded as a blended approach to manage teaching and training and learning along with supervised practice. So it shouldn't be standalone. It should work as part of the other learning episodes that all of us use. The most important bit being appropriate feedback and performance debriefing that would help people learn better and then allow for reflection and then re-practice. We've heard this already before from the previous symposium, where practice and practice and practice makes it better, and the feedback and debriefing makes all the difference. The various methods that could be included in this was suggested by us to the various SSCs when they started to look at the mapping exercise. They could use scenarios, benchtop, low fidelity, high fidelity, cadaveric material, virtual reality. What was being impressed at the time was simulation is expensive, but it does not need to be expensive. It can be based on simple scenarios. It doesn't have to spend lots of money on high fidelity simulators. So training facilities were recommended that there should be skills labs available locally and regionally, with basic, intermediate, and advanced skills being practiced in these places, where appropriate courses could be used to acquire the skills as long as they met the objectives as set out in the curriculum. And the bit at the end, professionalism and leadership, including human factors, had to be built into all the curriculum to make sure that we were not practicing technical skills only. So we eventually created a simple template and gave it out to the various people who were organizing the curriculum to start to work on how to map against the learning outcomes and how simulation would help, which then led to this template which was being prepared for submission to GMC. A fourth column in the curriculum was created which said areas in which simulation should be used to develop relevant skills. And two categories were recognized: strongly recommended and desirable. I'll come back to that in a minute. Objectives would meet these recommendations will meet the objectives as appropriate. Just another example of what one of the curricula looked like. This is a urology curriculum. Just picked a screenshot of urinary tract infection. And clinical skills, it was felt understanding infection, correct antibiotic therapy. These were strongly recommended, could be done in a simulated environment for trainees in the early years. And then the advanced technical skills were desirable. Similarly, there's another screenshot which again talks about strongly recommended, which is life support courses, critical care, ATLS and APLS. In the UK, ATLS and APLS are the only two mandated courses for surgical training, so we included them in that part of the curriculum. The desirable ones were team working and human factors. The terms strongly recommended and desirable were requested by the GMC, as they felt that we could not strongly recommend everything, as the availability of these courses or these training sessions or the programs would require a lot of funding. There needed to be equity, and everybody needs to be able to access it, and we needed trainers for these. So strongly recommended should be achievable by 2014, and we've started to roll out as of end of last year for course surgical training using simulation. Desirable courses to be put in place by 14-15. I think it might go on a bit longer unless we find some more funding somewhere. We finally submitted this to the GMC so that we met all the 17 standards of the curricula. We had agreement from various stakeholders, and the list is there. It was important that we had the employers, the training committees, the deaneries, and the patient and lay representative agreed to most of these things, and they were submitted on behalf of the College of Surgeons. GMC, after 2 iterations, finally rubber stamped it and approved the curriculum with inclusion of simulation as of July 2013 for all the specialties up there. Professionalism is included there, and it weaves its way through each of the specialty training program. It is now included in the ISCP, and as you can see on the page, it says including simulation as of October 2013. So it is there. It is not truly as part of the curriculum, but it's been mapped into. That's the challenge we have now, is to make sure that that is implemented and it has got all the detail in it. So the proposal from the simulation group was and to answer some of the questions from GMC, which we will have to provide answers for in a year or so, is to audit the provision of simulation facilities as of now, the access to simulation for trainees, and equity of access. Do we have trained trainers, and how do we provide training for trainers? Are there training courses? And to audit the uptake of strongly recommended courses, availability and access to simulation scenarios for technical and non-technical skills. So we're working with other associations, including HE and ASPI, who are helping us look at the provision of facilities across the UK. Further proposals, we would need to QA the various programs. The courses need to be QA'd and mapped against the outcomes. GMC has suggested we should start to look at the use of simulation for summative assessment eventually, but we are still not ready for that. We need training for trainers, and I borrowed this bit from Craig's previous slide, training for trainers using 3 levels: basic trainers, faculty for courses, and advanced trainers, which is 3 different levels. The basic trainers are the ones who would provide training on site, and the others would provide the advanced courses. The plea is now for all the SACs to start putting more definition into the curriculum so that we make it more effective and more useful. Thank you.